Oh, 2-minute warning, 2 minutes. Yeah, I can do that. 4.5-minute warning, readjusting. No minutes?
Good to go, good to go.
No minutes, it's not an official meeting.
Good to go.
Let's see.
They got it.
Yeah, keep us from tangling on you.
At the next conference, we have to get a deal with Pandora or something, so we can actually.
Yeah, amen, sir.
That's
the license.
part of the whole thing.
That is true.
Mike Sag playing guesting that too. He's good at it.
We're gonna. Somehow got hung up. Oh, let's see what happened.
Whoever the speaker was.
No, it's just me.
That's just you?
We have a bunch of panels.
For the rest of the panel? Okay.
Oh, you.
I'm just
Oh,
gonna.
okay.
I have to. Unless you, if you want to do introductory slides, I don't. You just want to start this. We just need to do a few introductory slides. Okay, we're going to get started with just a few housekeeping issues. Next slide. So we do have concurrent workshops immediately after this. Once again, your workshops that you signed up for should be on the back of your name tag. If you've decided that you really want to go to a different workshop instead, all the workshops are pretty much fully subscribed. But feel free, you can stand in the back of the room, let everyone that signed up for the workshop come and sit down. Once the workshop gets started, then you can take a seat if there's seats still available, or you can hang around in the back if you decide you want to go to a different one. Another issue is that the evaluations, ability to evaluate the morning sessions are online, so you can go to the IASUSA website and then from there can click through to the evaluation and start doing the evaluations. If you want to get CME credit, nursing credits, AFFP pharmacy, MOC, you need to complete the evaluation and the final evaluation before September 29th. And lastly, we do have some affinity groups. If people are interested in affinity groups, they're starting this evening at 5:15 and then continuing tomorrow morning. And the affinity group sign-ups are outside on the table. There are a lot of very interesting topics, so if you're interested, please look through those and sign up. With that, I'm going to turn this over to Mike Sag. I think this next session is a highlight of the clinical conference. And Mike.
Thank you, Laura. Okay, so we got 60 minutes and about 10 cases that we're going to go through. Those of you who've seen me do this before know that I start with a question and then create a case around that question. Those of you who've seen me before will probably be thinking, oh, this is the same talk I've seen before. Not quite. Some of the questions stay the same, but the answers change over time. So you've got to pay attention a little bit. We have some new folks to introduce you to. Immediately to my left is Dr. Jeannie Marazzo. You will hear from her tomorrow. And she is the division director at the University of Alabama at Birmingham, as opposed to the Ohio State University. From the Weill Cornell University, Dr. Trip Gulick, who is also chair of ID there, and Dr. Kristen Wagner from Yale, the Yale University, and who is on the panel as well. And I think the rest of the folks spoke or were introduced earlier. So without any further ado, let's get started. These are my disclosures. We're going to talk about starting therapy. We're going to talk about PrEP a little bit and what's a type 1 and type 2 MI. The guidelines exist all over the world. There's different types. Trip is in charge as one of the chairs of the HHS Guidelines Committee, and so we're not going to spend much time about when to start because the answer is everyone as soon as we can, for the most part, except for maybe one we'll talk about in the first case. And then the ISUSA guidelines, which came out last summer in JAMA. So, seems like we are now starting ARV therapy for about everyone. What do we do for an elite controller? And that was one of the questions that came from the audience was, what if somebody naturally has undetectable virus? So here we go. 30-year-old guy was diagnosed 4 years ago. He's asymptomatic. His viral load consistently has been less than 50, and the clinicians were wondering, was this a false positive antibody test? The answer, no, the DNA was positive. CD4 count has been consistently stable at about 850 to 900. HLA-B57 was negative. Took the DNA and ran resistance testing on it, and it was wild type. No prior medical history and no other therapy. He's okay to start if you think he should. So would you start therapy at this time? Yes, no, maybe. And we're going to go to the voting ASAP. And when the green light comes on, I'm going to provide the music. Believe it or not. Ah, right. Thank you. Green light? Not yet. Wait for it. Is it on? Yeah. Hello, Opie. No. I'll do my own music, thank you. All right. So most people would. Panel. Dr. Deeks, let's start with you because you have been the elite controlologist for such a long time. You're on.
So yeah, elite control is not a state of normal health. If you compare elite controllers to people who don't have HIV, they have clearly more inflammation. Many of the inflammatory markers are up. Cross-sectionally, they appear to have excess amount of atherosclerosis disease or vascular disease. A study in San Francisco and a study in Boston showed that. They do have a rate of CD4 decline that is slow but real in some people. And there's been some sort of cohort studies suggest that they get hospitalized more than you might expect. So it's better to be HIV negative than to be an elite controller. Then the question is it better to be an elite controller off ART or one on ART? And there it gets a little tricky. It's clear that when you put an elite controller on antiretroviral therapy, a lot of these indices, these biomarkers get better, the inflammatory stuff goes down as you might expect and so forth. But you're really, in that setting, you're trading off kind of the theoretical concerns of long-term antiretroviral therapy with the theoretical concerns of chronic inflammation, and I'm not entirely sure we have the capacity to say which is better. So and we have a cohort of 200 or 300 of these people over the past 10 years, spend a lot of time talking to people about the pros and cons. I think the risk of HIV transmission is negligible in a elite controller, but probably not zero. And you know, I talk to patients and I say, listen, if there's really nothing going on, probably no reason to rush into this. But if there's something going on, particularly a CD4 decline or a low CD4 to CD8 ratio, or concern about their sexual activity or high CRP, then I would be inclined to treat.
So what would you do in this particular case?
I actually wasn't paying attention to the details. Can you go back to
The details are he's a elite controller, CD4 counts age 70, feels great, 30 years old, guy.
I would punt. There's nothing there to suggest I would. I think these drugs are toxic. I think inflammation is toxic. I don't want either one.
Inflammation's toxic. Drugs are toxic.
Yeah, so in a 30-year-old guy, I'm going to put him on lifelong therapy.
Okay.
I would like to know his CD8 ratio, how his worldview on things, his comorbidities, this and that.
So I think what he was doing was punning because he knew what my next question was going to be, and that is that with your cure research efforts, you basically are creating people with elite control. And the trap I was setting up for you is that if you had said, treat this guy, I was going to say, well, then how come you're getting all these other people to an elite control status and stopping their medicines?
I gave you the right answer
Of
then.
course you did. You saw it. This is from a life and
I tricked
others.
Mike Sag. What do you know?
All right. So any other comments from the panel? Anybody who would treat for sure, pretty much? Joe?
I just think one thing is these kind of super elites that are always less than 50 are pretty rare, and you know, some have blipping, and I would be more inclined to treat the person, especially if there was any kind of CD4 slope, just as Steve said. But I think I would be a little bit more inclined to pick the least toxic of our combinations, and this might be someone where, you know, something like, you know, dolutegravir 3TC,
Yeah.
or
That was why the wild type DNA was important, because you wouldn't want to do that. So we got a lot of other cases. I know we could spend a long time on this, but these are data from Steve Deeks' group with Peter Hunt that showed that the elite controllers had a little bit higher stuff. Jeannie?
Are you finished with this case, or can I ask a hypothetical question
You
about
can
this?
ask away.
So he has a negative partner, an HIV negative partner.
Yeah.
He's in a discordant partnership. Would that change your recommendation at all? Do we know anything about genital shedding in
What do you
elite
guys?
controlers?
The genital shedding question.
Sorry, I just
You-
have to
it will-
get to the
it will
genitals.
shed,
you know.
that's for sure.
You know, I
by
have
PCR.
I'm meeting with someone next week. He's a heterosexual relationship. His wife has never been fully comfortable with the fact that he's got
Infected.
HIV, even as a lead controller. It has had an impact on her sex life. I'm telling him to go on therapy just so his wife can relax.
Sure. The answer is totally unknown, for 100% confidence, but if you just extrapolate, there has been no transmission of any person to another person through sexual activity when the viral loads are less than 200, and even back in the old days, less than 1,000 off therapy when the Rakai study out with Tom Quinn. I think 1,000 is a little bit too high, but if he's consistently less than 50, I think it's virtually zero, if not absolutely zero.
And if she's worried, she could go on PrEP herself.
There you go. So treat one or the other or whatever. We're going to get to both in a minute. Kirsten.
Just one observation. So I have 3 out of 160 patients who are elite controllers, but prior to inheriting them, they had really all heard that they didn't need antiretroviral therapy, and so rather than sort of seeing somebody sort of de novo and recommending it, I found that they were very resistant to
Yeah,
it.
absolutely.
Yeah.
Just that's not what they
So
had
the
heard.
operative phrase on that first case was, wants to start therapy if you think it's a good idea. And if they don't think it's a good idea, probably leave them alone.
The one thing, Mike, just is to make sure they stay in follow-up, because
Yep.
sometimes they get the message, A, they don't need therapy, and B, they'll come back when they don't feel well. And that they can certainly progress.
We should also be really clear, there's no clinical trial data to help us with this decision. Steve, you framed it well, that the bad stuff about inflammation versus the bad stuff about taking drugs. And that's how a clinical trial would help us answer this question. No one's been able to do one. The ACTG tried one and they could not enroll the
it's
people
not
because
enough.
of Kristen's point. People either did want it or didn't want it, but they didn't want to be randomized.
Okay, so shifting gears, we have somebody who's maybe more straightforward, that's not an elite controller, who needs to have therapy started. So what would you start? So here's the story. 48-year-old guy, asymptomatic, HIV RNA's 28,000, CD4 count 650. He's HLA-B5701 positive, genotype wild type, normal renal function. Okay to start if you think he should. Most everybody would. So give you time to digest this. It gets worse on the next question. But look through that, and it's going to take a lot of steps. Let's go ahead and open up the polling. And while we wait for the little number, you can be digesting further. And yeah. So we have votes coming in. We got 2 so far. Now we went down to 1. Okay, I don't know how that happened. Retreat.
Withdrew.
It's a wonderful day in the neighborhood, a wonderful day for a neighbor. Would you be mine? Could you be mine? I figured it's better than elevator music. Oh, well.
Let's take a vote on
Okay, fine. Whoops, went off. There we go. Oh, there we go. So a lot of them went with the Joe Iron regimen mentioned earlier today, which is, I think you said was your favorite. They don't mind taking 2 pills, which is the TAF-3TC dolutegravir. I'll just open it up. Panel, is there any wrong answers up there?
Yes.
Okay.
So the second one down is incorrect. So
Great.
8% of you voted for an abacavir
6%.
containing.
Yeah.
Jeannie's eyes are better
Only
than mine.
6%. Well, you don't want to. You want to give
Some
them the benefit of the
percentage
doubt.
of you voted for abacavir containing regimen. Remember, he's HLA-B5701, so that's correlated with the hypersensitivity reaction. He was
Yeah.
positive, according to the slide. So if you miss that, don't miss it in clinic.
What? More than me, you mean? Yeah. Why don't you put on, just see if you get cut off. I don't think it will. All right.
I'll chime in and say the one other one that I'd be nervous about using here is the next to the bottom, dolutegravir 3TC, just because we have incomplete information on that combination here. There's some nice single arm studies. Joe reviewed one today that was presented, but we don't have the complete or comparative information. So I might say that that one should not be used routinely right now, unless there's a really good reason to do it.
Bill, there's no contraindication to the first regimen. I would never go to an efavirenz-based regimen for starting. In fact, I would probably try to switch most patients.
Yeah, we'll get to that later. But you're right, it's amazing to me, just as an editorial commentary, that in 2007, that top regimen was 87% of new prescriptions, and all of a sudden it's, no, don't do it. But that's where it is. How about rilpivirine? Assuming, no food issues and no PPI?
I would say it's incredibly well tolerated,
Small tablet.
pill. This person's C4 was greater than 200, obviously, and the viral load it was less than 100,000. So I think that would be a very reasonable regimen. I would say that I see first-line failure with drug resistance uncommonly these days, very uncommon. But if you mess up on a rilpivirine-based regimen, you can end up with easily two-class resistance, and sometimes both 65R and 184V.
The other thing I think is challenging with that regimen is that you do have to take it with a full meal, not just a snack or a protein bar or a protein shake, and that can be tough for people to do it.
Okay, let's change the case around. Same guy, except now when he presents the CD4 count is 21, his HIV RNA is 760. I'll make him now HLA-B57 negative, so we already made that point. So wild type, normal renal function, okay to start. I took out the dolutegravir 3TC, and let's go ahead and digest and vote. And the person who came up just said, stop singing. So I said, okay. I'll just hum along. Oh, okay, thank you. I'm here all week. All right. Let's see what we got. All right. So a lot of people stayed with the Eron regimen. Let's see, are there some wrong answers here? Indeed there are. Dr. Gulick, you seem to be the taskmaster, so what is the wrong answer on this one?
So the rilpivirine regimen, number 4 on the list, because his CD4 is under 200, that regimen did not perform as well in that group and should not be used here. So that's one to shy away from.
Okay. Any other comments about, does it change much of what you think when you treat if the viral load is very low? Make you want to go with an integrase more than a PI? Faster resolution of virus? Does that make a difference?
We used to spend a long time talking about this, whether NNRTIs versus PIs, and the Europeans in particular really like to use PIs in advanced patients, but the clinical trials really never backed up that approach. I'm not aware of data that shows the integrase inhibitors work better in
They're
advanced
faster.
disease.
They're faster to zero.
Faster, we always think faster is better, but is there any clinical correlation with that?
No, but that's
Yeah,
just
that's
called
never
the
been shown
NASCAR way of thinking. It's very popular in Hueytown, Alabama.
Faster.
Yeah.
Go,
I mean, actually, there's some pushback lately, right, that maybe integrase inhibitors are more likely to be
Cause
associated with
iris.
iris, right? Which, I don't know that that's true, and that wouldn't affect my choice, but I've certainly heard that pushback recently.
Right. Kristen?
Just, you don't have a lot of time for this patient to get on board with his regimen, so you certainly want high acceptance.
Yeah.
And so, the darunavir-cobicistat combination, they might have trouble tolerating it, swallowing it. So I would not be inclined to do that.
It's a perfect lead into my next question. So everybody bear with me. I'm going out on a limb a little bit. So I want to see how, because I knew this audience would be kind of with it, and as you showed in your answering of questions in the earlier talks. So let's do a little predictions here. So let's pretend it's a year from now. It's August 2018, and bictegravir has been approved. And let's assume there's ample evidence now with dolutegravir 3TC. So it works. Let's say that's confirmed. We're going to go back, shift your gears back to the same guy with the CD4 count of 650 and a viral load of 28,000. And here we go. And this is fast forwarding a little bit too. Let's say the cabotegravir rilpivirine IM is now available. It won't be by then, but let's assume it is. And you do the lead in, you can give them every 8 weeks IM injection in your clinic after the lead in. You can give all the other fixed dose. Bictegravir is now out as a fixed dose combination with TAF and FTC. I think everything else is pretty much the same. We got rid of efavirenz.
And you have a single tablet protease. That'll be available at the same time.
Right, so that's, yeah.
Number 6.
Number 6.
Number
let's say
6
it's
is
a
now
single
one tablet that's
Let's say it's
the
one
size of your fist, but it's available as a
No,
suppository.
It's no
And
bigger than.
yeah. Okay, so go ahead. I'm not trying to bias you. Now let's go ahead and vote.
Joke has been around as long as phosphorus.
Enough.
It's making me
Please.
sleepy.
Thank you.
Whoa.
Whoa.
All right, so BIC won the day, followed closely by, not closely, but followed by Cabo rilpivirine. So a lot of early adopters here. How does our panel feel?
I'm pretty shocked with
Shocked panel.
these results. Hopping on the bictegravir train, are we? Wow.
Well, that's one pill.
Yeah, and Joe showed the phase 3. But thank you for showing that.
You can go over it tomorrow and go over it more carefully.
What's interesting is that the protease inhibitor seems to have taken the biggest hit more than anything else. And, oh, I'm sorry. Some people might have been, because I said go back to the first, and then they were HLA B5701 positive, which could have had impact on the dolutegravir vote with that fixed dose combination. Sorry, I should have made that clear. But nonetheless, let's talk a little bit about the Cabo rilpivirine. Yeah.
I can't imagine that people really are going to want an intramuscular injection every 8 weeks. I mean, they hurt, and the injection site tenderness in that study was not trivial.
Right. So we didn't say this earlier, but for those of you who have been participating in the studies, these are 2 ml injections.
It'll be 3 mLs if it's every 8 weeks.
For every 8 weeks. 3 mLs.
2 3 ml injections.
3 mLs, one for Cabo, one for rilpivirine, every 8 weeks in each buttock, as Forrest Gump would say.
I'll be taking a pill.
All right? Now, all of a sudden that may change views, huh? Well, it's sort of like having syphilis every 8 weeks, which some people do.
Well, they're already doing that.
They're already doing it. So we'll co-formulate it with penicillin, and it'll be PrEP for syphilis. What do you think? Dr.
I like
Marazzo?
that. That's an excellent idea.
Yeah, there you go. We'll show the syphilis bug, yeah, that spirochete will be on the run.
To be fair, in the Latte 2 study, the participants did find their treatment acceptable.
That's true.
And when they reached 96 weeks, they could have gone off the study, and virtually all of them chose to stay on. It certainly is uncomfortable. There's no question about it. It tends to get less uncomfortable with subsequent injections as the injector and the patient become more comfortable, so they're less tense.
They get calluses?
No,
I'm kidding. So
It's not like the T20 injections. We
Right.
should say that. Very
Right.
few people drop out because of that. But there is a selection bias here. I mean,
No, of course. No, I'm not.
you're-
I'm just.
This group
it was,
volunteered to
Sure,
be
absolutely.
stuck in the butt
Right,
twice every 8
absolutely.
weeks.
So everybody's made the points that are, I think, germane. Number one, we think T20 when we hear ISR, injection site reaction. That was a sub-Q injection twice a day. And so it starts off with a lot of enthusiasm, and then these bumps sort of don't go away for a week, and it's like having mosquito bites 24/7. And the second thing is that this is every 8 weeks, and maybe it's a little bit like labor that people tend to forget over a period of time that it was painful, and they go through it again. I don't know. But you're right. On the studies, People have stayed on. The ISRs are mild to moderate for the most part. The dropout rate is very low in the studies. The question is, the type of patient who's going to really, really, really want this is, as Glenn Treisman say, the feeling-driven patients. And if those feeling-driven patients can't sit down, maybe they aren't going to be happy. Tony.
You know, when you put this up, I thought it was a little bit hard to ask us to answer this question because it doesn't really factor in the patient bias. You know, I mean, how are we going to say,
Well,
oh, you know, they're going to elect or not elect to do an injectable? So that factors a little bit into what they're going to want. But I can tell you, as a Latte 2 investigator, you know, patients do report injection site reactions when you ask them, but they don't complain about the injection site reactions. And the other thing I think that's really important is, you know, these patients, and we've been taking them now for, you know, a couple of years, when they come to the office, it's a completely different experience. You know, it's almost like the old days where people were getting testosterone injections and they come to the office and they're like, hey, I'm here for my injection. It's not, hey, I have HIV and I have to come here because I'm sick and get medication.
Right. Yeah.
So it really is a different mindset thing, and there are a group of patients who really don't like to look at that pill bottle every morning and think I have HIV and I have to take this. Or people who live in situations where they're living with their family or their friends and people don't know and there's stigma and they can't disclose. People who are traveling and want to be gone for 3 weeks on a shoot or something somewhere.
It's liberating.
So there's a lot of things that factor into that.
Right. So that's the reason I put this in here, is to, in fact, have this discussion to get everybody thinking about this in your practice, because it's coming. I think, if I had to summarize, that the angel's in the details, right, in terms of who the patient is and what the data ultimately show, the motivation on the part of the patient, and what that profile is. But I think what the audience response of 30% without the details says that there is a recognition by experienced providers like who are in this room that there is a desire to find some alternative to taking pills every day. And maybe as people get older, that becomes moot because folks are taking 5 to 7 to 12 other tablets a day, and what's another 1 or 2? But I think especially for younger people, it can be liberating. And we'll talk about PrEP later, where this might be at play. Other comments from the panel before I move on? Okay, that was a point of that. It was just a thought exercise. The regimens we'll probably be using the most of in the future are the ones that we picked. I think we're going to be leaning more and more towards integrase over time, and whether long-acting comes available, we'll have to weigh that out. In fact, the estimates are that Cabo might not be available commercially till early as 2019, maybe 2020 early. So it depends on how fast they can get the studies done.
Mike, you took out L-Vitegravir off that list.
Oh, I did that. Yes, let's talk about that. Part of the reason I thought, and you all can push back, but if you had a choice between an effective integrase that did not require boosting and one that did require boosting, my assumption was you'd pick the one that didn't. Is that wrong?
No, I think we should avoid boosting if we can. I mean, I think that's unequivocally true. And I think the only thing about bictegravir is that, we have 48-week data on, 650 some odd individuals. And it depends on how conservative you are. I mean, we have, tens of thousands or hundreds of thousands of patient years of dolutegravir data, and millions of patient years of raltegravir data. So it depends on how conservative, and we all like shiny new things.
Well, it is a bit reassuring that it's in the same class.
Yeah. No, of course, in structure it's very similar, and the studies are virtually kind of overlapping in their results. And
but the pharmacology is quite different and far more complicated, right, for detecting the drug-drug interactions.
For what now?
Bictegravir? No.
It's pretty similar.
No, it actually has less of a metformin. That's, it has slightly less of a metformin interaction.
But it interferes with 2 different pathways. It tends to make it more complicated to predict what's going to happen. And they're not doing all these drug-drug studies. That's my understanding.
Okay.
Well, I almost took darunavir off because of the boosting, but I figured, well, there'll still be some folks who are more comfortable with PIs. But it looks like this is where the future is headed, and then ultimately to long-acting. So I just wanted to put that out there. And then for cost, these are the minimal cost in developing countries, and I've shown this to folks before. Look at the dolutegravir 3TC as far as cost of goods for, this is an annual, this is 1 year budget. Yeah, 1 year. I'll let that percolate as we go through the rest of the lecture. Yeah. Okay, so what regimen should be used when there's an M184V present at baseline? So we've got a 30-year-old woman, newly diagnosed, viral loaded remarkably is the same as that guy who was 48, don't know how that happened. B57 negative, but genotype instead of wild type shows an M184V, no past medical history to speak of, doesn't have children, and doesn't at this time plan to become pregnant, although she might, and okay to start therapy if you think she should. Similar listing as the very, very first case. Let's go ahead and digest and vote. Hold on till the green bar comes on. There we go. God, it sounds like a funeral parlor. Okay, thanks. Okay, so we're back in the current time. So the majority of folks went with the same they did before, basically. A little bit of moderation around the abacavir went up a little bit to 10%, if I'm reading that right. And comments from the panel? Just more of the same?
I think they picked the right regimen based on almost as if this person was a kind of a first-line failure, with a 184V, and we know that from the data that was at IS and previous data, it's either a boosted PI plus nukes or dolutegravir plus nukes, and those are the two. I personally would not prescribe dolutegravir abacavir 3TC because of the interaction, the impact of 184V on tenofovir susceptibility, making it more susceptible, as opposed to abacavir. 184V decreases the activity of abacavir slightly. So I would not have picked the second choice, but I think for the rest of the folks are right on with either whatever it is, 5 and 6, I guess.
So what people did was really avoid the third drugs with the low barrier to resistance because you're concerned that you've lost one drug. So
Dr. Gulick is a school taskmaster. Is there a wrong answer there?
So non-nukes, you would not be happy with taking tenofovir with FTC or 3TC since you know it's going to be resistant, plus a non-nuke. And then similarly, the two integrase inhibitors with low barriers to resistance, elvitegravir and raltegravir, you'd be more hesitant to use those as well.
What about number 9?
Number 9,
Number 9.
DTG and 3TC. So that essentially you're converting that to dolutegravir monotherapy, and we know that's going to fail in some proportion of people.
Yep.
So I wouldn't have used that either.
Kristen, you had
I was going to just make that last point.
Oh, I'm sorry. Okay. So I think the summary is it doesn't change a lot. I mean, but I remember back 10 or 12, maybe longer years ago, when we started doing more routine resistance testing prior to the presence of this M184V made people very, very nervous, and to the point where they wouldn't even use FTC or 3TC in the regimen. And that really isn't the case, as you can see here, partly because of everything that was said about the relative hypersusceptibility of tenofovir when placed in context of an M184V, but also something that, Joe, I believe you did a study on this in 1995 or so that showed 3TC monotherapy in the presence of this still had about a half to 0.6 log activity, right?
That was your high school project.
Yeah, that's right. It was a science project. He came in second.
Right.
Lost out to the Eclipse project. I don't know how that happened. Yeah. So there we go. Okay. Now, this is the question of the year. So should I switch from a efavirenz FTC to tenofovir TDF in a patient who's been on it for 10 years? So a 45-year-old woman, not in your practice, gets referred, so she's new to your practice. She comes in 10 years ago, was diagnosed with HIV, there's her initial viral load and CD4 count, and she's done pretty well. Her viral load's undetectable, her CD4 count's been consistently above 500 the last several years. She was started on that fixed-dose combination, whose name I can't say out loud, ATRIPLA, only regimen that she's ever taken, reports no symptoms, generally feels well. What you gonna do? Change your regimen. Change her to 2 nukes and rilpivirine, 2 nukes and a boosted PI, 2 nukes and an integrase inhibitor, or some other kind of thing. This is a huge data-driven question. Okay, so over half would change to an integrase. A third would stay the course, wouldn't change, wouldn't be prudent. Kristen?
So I voted for the change to the 2 nukes and the integrase inhibitor.
Okay.
And essentially, my practice has been to have a conversation with everyone on that regimen and to go through an assessment of whether we think they have any symptoms that are efavirenz-based, any depression, any sleep disturbance, any sort of cognitive fuzziness in the morning. And even among people who don't necessarily recognize those symptoms, I encourage them to think about a switch, because in my experience, often when people do make the switch, they've said that they feel better. And frankly, I just don't have that many people that don't have some degree of depression that might be partially relieved by the switch. So that's been my practice to get most people off of it.
So a third of folks said it wouldn't change. Anybody on the panel want to speak up for that?
Yeah, I think it's okay.
Yeah, Marshall?
Okay.
What do you think?
I just to finish this, I saw a patient last week. Who is this patient, essentially? He's been on this triple combination for over 15 years. And I said, you know, there's other options. And he's like, I don't want to switch. And kept saying it over and over and over. And got a little testy. We talked about TDF versus TAF. I don't want to make that switch either. I just want to stay what I'm on.
Right.
So I ended up wanting to preserve the relationship and saying, okay.
You just, no, what you did is you transferred his care to Marshall. Marshall, what did you say?
Just by way of full disclosure, I saw the patient on lamivudine, nelfinavir, nevirapine, who came to me on that regimen and refuses to switch off of it. So there's some people who just want to, you know, won't switch no matter what. And I have I think similar to Kristen, have the conversation, try to assess whether, you know, I don't know if this woman's menopausal status. I think you said she was 45. You know, if she's postmenopausal or going to go through menopause soon. The bone loss could be, you know, an issue with TDF, and that might factor in. Talk about the suicidality data with the efavirenz, but I think the risk is relatively modest. So,
2 quick questions from the floor. Yes.
Well, that was I chose something else because I was more concerned from the tenofovir component of that regime than I would have been from the non-nuclear side. So I would have been making the move because she's 45 and a woman. And you guys, you know, the data on TAF is supposed to be bone sparing, and I hate to tell you, there's nothing worse than naggy, crying individuals with broken hips, and I'm not ready for that.
Good point.
Just wanted to add, as these folks are getting older, there is more drugs that you're adding on, and efavirenz has a lot of drug interactions because of the enzyme buildup, particularly with the lipids, the statins, and so on and so forth.
Yeah.
So that would be another reason for I would consider.
All good. Jeannie.
This regimen, and they have regular insurance, commercial insurance, and their insurance pays for a 3-month supply and no co-pays for both of them. They have no renal issues, and I think what you need to do is present the information, make sure that they understand if things are changing, that you may have to change it, that we have options of supporting them with, pharmacy copays, but it's really hard under certain circumstances to make that change.
Yeah, usually the payer wins at the end of the day. I don't know why. It usually happens. One more comment and then we'll move on. Yes, please.
Hey, Alex Gonzalez from Fenway Health in Boston. I would just add that if you have international patients, ATRIPLA is much easier to get if you run out and happen to be in Africa.
Good point.
Yeah.
I think the take-home point is that the efavirenz-based regimen is, I think we'd all agree, suboptimal now, but it's not horrible. I mean, it's not like nelfinavir or lopinavir or something like that causes diarrhea every day. So I think this is what I wanted to have discussed. I don't think there's an absolute here. I hope you're taking that away. And you individualize just like we've talked about with other patients so far. Now, should I give PrEP to the seropositive partner? I've been asking this question in this case for 3 years, and I will tell you the answer has changed dramatically. So let's see where you guys are. 45-year-old guy makes an appointment to request PrEP. Partner is positive, but has been on successful therapy for 17 years and has never had even a blip. Generally feels well. The partner who's coming to you, who's seronegative, he's had no past medical history, no medications. He denies any outside partners outside of the relationship. And what are you going to do? And I know you're going to talk to the patient. All right, fine. But besides that, please. All right, let's go ahead and vote. Then I've got a twist. People are much faster answering this question than 12 other choices for antiretroviral therapy, I'll just say. So this is dramatically different than it was 3 years ago, where a majority of people said, not going to do it. And now people say, okay. Dr. Marazzo.
Right. So you didn't say whether this was a male or a female partner, and I guess that one question is, does that matter? But I would say that in general, it would be perfectly fine not to prescribe PrEP here based on the current data. And if you follow, the partners data, which is probably the biggest database now that has like billions of years of condomless sex acts, basically there have been absolutely no transmission events in that study. And again, that's self-reported. It's sort of a real-world study, and that really complements all the data from the clinical trials where people who really were suppressed were really at zero risk of transmission. So CDC struggled with this because for their recent guidelines, they don't like to say absolutely zero risk, but I think everybody agrees it's pretty close to zero.
So the assumption here is that the accuracy of the history is there, that there is no outside relationships, and let's say they're living in a part of I won't start throwing bias. Dr. Gulick, you're from New York City. What would you do?
Rah, rah. Because this person came to ask you for PrEP, I would tend to support him and give him PrEP. He made.
Yeah, I wasn't saying you shouldn't give it to him. I'm just saying, did he want it? Did he ask for it?
Feels like a Trump
ask for
rally
it.
all of a sudden.
Okay. Did you just say? Did you just
build
say?
a wall?
Oh my God.
Did he just say I sounded like that?
No.
Okay, good.
He did not accuse either
No.
one of us of being
I was
Trump.
making general comments about the
I
audience.
was about to have
No,
a
I'm just kidding.
attack.
So, of course, Jeannie would have said the same thing. But this guy is coming to you. His partner's been undetectable for 17 years. PrEP's been out for 5 years. Why now?
Yeah.
And
That's a
so
good
he may
point.
not be volunteering everything that you need to
Okay.
know. And I would
So-
just support him.
I don't have a way to answer this outside of your hands. So this past week, an MMWR was presented about a different situation. Here's where you have a seronegative woman who's married to a seropositive guy. The seropositive guy is the undetectable one. The seropositive woman and the seronegative woman and the seropositive guy want to have a child. They want to get pregnant. So the question is, do you just say, get busy and let him go? Or do you put the woman on PrEP? Or do you do sperm washing? All right, so here's the question to the audience to make it simple by show of hands. How many of you would feel comfortable knowing that this seropositive partner consistently is motivated and has never had a blip, all the data that Jeannie just referred to? How many people would say nothing more to do, just let him get pregnant? Not as many as I thought. Some creeping hands. Yeah? What does the panel think?
Well, I think it's a slightly different situation than the one here, for two reasons. One is it would be very time limited to give the uninfected woman PrEP, presumably relatively time limited till she became pregnant. And there's a third party or eventual third party in the mix, and the risk to, if you had a transmission and a pregnancy at the same time. So I would be more likely in that situation to do it than in this particular, this situation.
Right, those are two separate things, right?
But it's almost a kind of a gestalt kind of feeling. I mean, much like Tripp had the feeling that maybe this partner isn't telling you something and wants PrEP for a different reason. So
this is quite a bit different in my mind, because these are totally committed partners who are wanting to get pregnant. It's time limited, as you said, so that might be there. But the data kind of scream that the risk of the seronegative woman of becoming infected is close to about as zero as you can ever get. I mean, it's certainly less than zero. I mean, it's better than looking at the sun at the eclipse and going blind. I mean, something like that.
Yeah, this bugs me a lot, because you think that two men are in a relationship and are totally committed, and so one of them is not telling the truth, and then you have a man and a woman who are in a relationship, but of course they're telling the truth.
Wait a minute. That's not the point here. Is that they come to you and they say they want to get pregnant. That's a bit different than I just want PrEP for PrEP. I think PrEP for PrEP, I'd agree with you, but this is, well, anyway, I won't defend it.
So, Mike, the thing...
And women who, if she... pregnant women are at greater risk of infection, and I don't know that... So women, I'm not sure the data you're quoting...
There are no data for that.
Although you're talking about periconception PrEP here, right? I mean, you're not talking about keeping her on PrEP throughout her pregnancy, right?
No, it's through pregnancy.
They're going to follow up very carefully.
Yeah, it'll be through pregnancy if you're going to do it.
As soon as she becomes pregnant, they're going to stop having sex or right.
Two quick questions or comments.
So I don't have a question, I have a comment.
Yeah,
I'm
please.
Jean Keller from Johns Hopkins. I'm the director of the Women's HIV program. So I just want to point out a couple of things. I think if a woman and a man who are serodiscordant are planning pregnancy, they need preconception counseling, number one.
Okay.
You need to know the couple. They need to know all the details.
Yeah,
and if they choose to take PrEP in that situation, that's fine. I do agree with you, the risk is low. You also have to look to make sure there's no STDs involved, and they need to be screened for STDs.
Sure.
So I just want to say that's also in the guidelines. There are preconception counseling guidelines now in the public health guidelines in the greater HIV.
So let me turn it back to you. Let's assume all of that is all favorable. They don't necessarily want PrEP, that all that counseling is done. Do you feel compelled to prescribe it based on data?
I actually leave it up to the couple. And
okay, if they said, no, we don't want it, you'd be okay with that?
I would feel comfortable with it if I made sure that they understand that they have to be monogamous and that they can't have other STDs, yes.
Right. Yeah, you got to the essence of it. Let me get this, and I'll come to you, Kristen. Yeah, sorry. We've got to be quick because we only got 15 minutes left.
Okay, Shauna Applin, Tacoma, Washington. So I think the thing for me is people don't stop having sex in pregnancy. And I would want to empower the woman that she has some kind of power. And so even in the setting where they both say they're mutually monogamous, I would be totally comfortable. We've got great data of Truvada in pregnancy in our HIV patients, to use it not just in PrEPception, but to continue it, because if they get HIV while she's pregnant, that is bad news for the baby.
Sure.
So I wouldn't say this is a time limited, in my opinion. When I talk to my women about it, I say conception, but also maybe during the duration of pregnancy, if they in any way remain high risk, I would want them to continue on PrEP.
Right. I was trying to make this low risk. Great point.
I have a similar question. I'm Nancy Kakoyanis from LA. I have a patient who's seronegative, already got pregnant without Truvada, and has a positive partner who's been undetectable for a really long time, and just didn't know, would the panel start Truvada on her in the pregnancy? Or?
So, I think the answer is
Well, I think one thing to point out is that her risk has been modified by the fact that she's pregnant, right? Pregnancy does increase the risk of transmission. In this case, are there data to speak to how much that's increased? I don't think we know, because he's fully suppressed. Yep. So I think you have to have that conversation, and I don't think there's a right answer.
Kristen.
I just wanted to also speak to the psychologic benefits of PrEP. So in the initial case, you had a discordant monogamous couple, and certainly for both partners, the fact that the negative partner is on PrEP can be extremely beneficial. And I have HIV positive individuals who simply are too nervous to be really sexually intimate because of fear of transmission. So it may end up benefiting both the people in that relationship.
This is a great discussion. Personally, unless I felt compelled, I probably, once they're into the pregnancy and all the counseling is done and they don't have a strong feeling, I probably would not prescribe. But it's a guess. I think these are great points and a tremendously rich discussion. Thank you. This came up in a patient about 2 weeks ago. When, if ever, should I use primary MAC prophylaxis? So here's the story. There was a woman who came to us who was diagnosed 6 months ago, but she didn't agree to take treatment despite the fact her viral load was over 1 million and her CD4 count was 15. Well, lo and behold, she finally came back, found religion, and started on an integrase inhibitor regimen, had a dramatic drop in virus, but oops, ended up with an IRIS type PJP that put her in the intensive care unit for a while. She got better. After 2.5, 3 weeks, she's now back in the clinic with a viral load of 1,200 and a CD4 count of 27. And she's recovered, and she actually looks pretty good. Would you start MAC prophylaxis? Yes, no, or don't know?
And remember your wine right program. It might be a mentor.
Music maestro. I think I like silence better. Sounds like Elton John trying to play Tiny Dancer while stoned.
What?
All right. So most people would. Marshall, what would you do?
Well, interesting. If you had gone back 6 months and she wasn't going on antiretroviral therapy, I think I would have then. The fact that her viral load is getting very close to being suppressed makes me less inclined to do it at this point, just because I think the risk when she's suppressed, even with a low CD4 count, is extremely low, which I believe led IS USA to change their guidelines on this. Although I think the DHHS or the CDC OI guidelines have not changed yet, or not changed.
So should they change? Can't ask Tripp that because he's chairing. But okay.
I mean, I think that Marshall said it all. I mean, I think the risk of if she's not anemic, she's not febrile, she's not doesn't have any symptoms.
Looks great.
MAC. You want to make sure actually she doesn't have MAC, and that isn't part of her IRIS phenomena. But I mean, adding another medication that is has some adverse effects and cost and. I just didn't know whether it was a Ryan-Weick metric. If your patient's CD4 is less than 50 and they're not on prophylaxis, you get a ding on your, So, but I completely agree with Marshall. I think you said it exactly right.
I think in the interest of time, I'll just cut to the chase and say that the metrics are to treat. So that's how 82% of you said to do that. The IS USA guidelines looked at the situation more from a biologic perspective and said, once the virus is out of the picture, the immune deficiency improves dramatically. Reason why she got IRIS to some degree, perhaps. Not that she suddenly got PJP and, whoa, bad coincidence. That thing was brewing and her immune system was unaware. And then when the virus finally came down from the stratosphere, her immune system kind of said, what the hell's going on? And attacked, and boom, she got sick. So the fact that she's better and the virus is undetectable, you could argue, I think biologically not to, but this is a moving target, which is why I put it in the cases. So I don't think you're right or wrong either way. I think you can defend it either way. Okay, this is a key question. We've got 2 more cases left and we'll get them done. Should I stop abacavir in a patient with coronary artery disease? And with apologies, this case is ridiculously convoluted because I wanted to get to a certain point here. So sorry about that. 59-year-old who started on treatment years ago returns to your care after 4 years. So he was with you, doing well, left. Now he's back. And on return, he's on fixed dose combination, abacavir 3-TC, dolutegravir, doing very well virologically. Cholesterol was elevated, creatinine's okay. He's a smoker and a diabetic, and oh, by the way, he tells you, I had a heart attack 4 months ago. And they put me on aspirin and statin and a beta blocker, and I'm feeling okay now. So you see why I had to make it convoluted. All right. So besides asking him to quit smoking, what else would you do? Would you continue his regimen, change him, or some other option? Let's go ahead and vote.
How long is he been on?
Pardon?
How long is he on this treatment?
On the beta blocker and all that, about 2 months.
No, the abacavir. How long?
On the abacavir, 4 years or whatever, 3 years, long time. I can make up other answers while you ask if you want.
I feel like I should be drinking a cocktail.
It's a birdie on par 4, number 7. Okay. So most people would get them off the abacavir, but 30% would stay the course. Marshall.
Well, I think you alluded to the smoking. I think that's a bigger problem than the guy still smoking, but I would change the abacavir to something else, probably TAF, as people, majority voted for. I think, the abacavir story, in 20 seconds, I think, the data are almost all observational. I think there are still potential biases, despite brilliant statisticians trying to adjust for reasons why people are being prescribed abacavir versus something else. But there's a pretty consistent signal across most studies. So that to me is a compelling reason, particularly in some with multiple cardiovascular risk factors and known heart disease in this case, to switch off of them. We don't know the mechanism, but it seems that current use is associated with it, or use within 6 months in most studies. So the risk seems to go down with stopping it, so I think I would, for those reasons, support stopping it.
Okay. Any countering views? All right, I will just, I probably would change it too, but just to be provocative, I'm going to turn to the audience for a comment.
Thank you. Carlos Cho, Senior Lake Charles, Louisiana. In this particular patient, if you were to choose a protease inhibitor, what would you choose? Would you go with indinavir or would you go with darunavir?
Well, that's why darunavir is in here, is because it's also been associated with increased cardiovascular disease. Although the point is that the abacavir, there is a biologic reason that emerged that says that it might increase platelet aggregation, which is part of the reason why they might say it's while you're on it and not when you're off of it. But the question to me in this case is, okay, let's say that's true. This guy's on aspirin now. Does that negate the effect? Hell, I don't know. But you see how it gets all convoluted when you start taking data from observational cohorts and trying to apply it to clinical practice. Yes, comment.
Doc Reed from Southeast Health District in Georgia. Just a couple other points with this too. Our lovely cardiology fellow comrades in arms love high-dose therapy now with statins imposed to my patients. So you have to really watch his dosages of his statins, because I guarantee you they're going to bring him to you with Lipitor at 80 or Crestor at 40.
Right.
Also, he's diabetic. His GFR is going to go down and down. He's smoking. He's probably a little overweight like me as well. And so his hypertension may or may not be controlled also.
Right.
So you really need to preserve his kidney function. Lamivudine's not doing you any favors there either.
Right.
But it's in the combo that he's on.
Well,
so
great points, especially if you're talking about going to something that has ritonavir or Cobi, because that's going to increase the high-dose statins to super high doses, right? In a lot of cases.
I just wanted to add one thing. In the observational data and from the original report from the DAD study, it was the people with multiple cardiac risk factors that had the MIs.
Right.
You could say this guy has multiple cardiac risks.
So I think it would be, at the end of the day, in some ways you could say, why not change, because you're trying to tip everything in his favor if you can. One other, this is the DAD study that Tripp just alluded to. And it seems to be a consistent signal in cohorts, though the FDA, if you look at all trials at the bottom, they didn't really see a signal. But on the other hand, to Tripp's point, these were not people with a lot of comorbid conditions. These were younger people in randomized, naive treatment studies who had very few comorbidities, so you don't see it there. And my final point is that something out of the CNIX group that Heidi Crane led, that when you look at type 1 versus type 2, type 1 is a heart attack that this guy probably had, which is plaque-related, versus heart attacks that occur in younger people, that among all patients in CNIX who had a heart attack, it was split 50-50. 50-50. So that means that half of the patients did not have a traditional type of heart attack. They had it because of supply-demand mismatch, oftentimes from crystal meth or cocaine or sepsis or you name it, and that is the issue. And so we got to be careful not to get totally directed towards thinking only the traditional risk factors and try to minimize these other things. All right. Got to go quick because I got to get to the last case. Should I change a regimen when viral load is low but detectable? Guy with a high viral load initially, CD4 count of 70, HIV RNA now is 85, prior value 62. Lots of different regimens, it almost doesn't matter. Now on dolutegravir, darunavir, and 3TC. No historical resistance. So the question is this sort of smoldering viral load below 100 at all times, but not less than 20? Is that a problem? Would you change his therapy? Yes, no, or not sure? Let's go ahead and vote. Okay. All right, so most people wouldn't. Panel, anybody would change here? Nah. I think the take-home point, Steve, you want to comment?
No, I mean, we've studied these and other groups have studied them, and there's no evolution. You do these, it's just a big reservoir making virus.
That's right. That's would be my view, is that we've got the de novo replication blocked. That is, the infection of an uninfected cell is blocked. Switching regimen doesn't change that. You're still blocking it. It's the residual reservoir from a very high viral load that's persistent, and every now and then just sort of spitting out virus from the latently infected pool, and you detect it, and that's that.
The only thing I would say, Mike, quickly, is that if it was someone who had that really high viral load and then was suppressed less than 40 or less than 20 for a long period of time, and then was in this 85 to 100 range, again, I wouldn't switch them, but that would make me a little bit more anxious than someone who, because I've had patients like this that through all 10 years of their existence have smoldered, between 50 and 100. If there was a change.
I don't think I would, but I would clearly watch for it to go above 200 to 300, and then you've got a problem.
Right. No, I wouldn't switch, but I would feel differently about that scenario.
Right. Let me go to the last question, because it's the MOC reference that you remember, the maintenance certification questions. I got to get to this. So what should I use as initial therapy in a pregnant lady? So 2.5 months pregnant, comes to you newly diagnosed, viral load 28,000, CD4 count 650. I seem to be stuck on that value. B5701's negative, wild type virus, first pregnancy, wants to start therapy. Pick a regimen. I will warn you, this is a trick question. Ooh. Slow responses. Folks are not quite sure.
It's the music, Mike.
I think it is the music. Post-lunch, post-eclipse. Tough out there.
Post-eclipse, post-lunch.
All right, that's enough.
Yeah.
Okay, so similar answers to what we had with the guy in the very first case, except more PI use, especially with atazanavir. And Joe, you alluded to this a little bit. Do you want to comment on data?
Yeah, well, I think the issue has to do with guidelines here, right? And a couple of things. One is we have no information about TAF in pregnancy. So I think that it may be fine, it may be perfectly fine, but since we have no information at all right now, we would take off all the TAF. And then I think that, again, I showed dolutegravir data from this morning, and it may be that the guidelines will change based on, but right now dolutegravir is still not recommended first line for pregnant women. So I think actually I don't remember, the second from the bottom actually is the choice that would be.
And actually the top regimen, not so bad.
And the top also, right, sure.
With the old faithful.
The other ones to throw on the list that are not recommended in perinatal guidelines for pregnancy right now, cobicistat is not recommended.
So let me just go quickly, because this plays to that MOC question. There are PK data that is a little concerning, that the TAF has 4 to 5 times higher levels intracellularly in the fetus. And does that mean anything? I don't know, but data need to mature in terms of clinical stuff, and we don't know. So right now, TAF, that's why you don't see it in the guidelines, because there's a signal that there might be increased risk of toxicity, not to say that there is a toxicity. And the same thing's kind of true for dolutegravir. There hasn't been fetal toxicity in the studies, but there is a high placental transfer leading to higher levels of dolutegravir in the fetus. Does that mean bad things? Not necessarily, but does it mean it's okay? No, not so far. And Joe's data is the first. So on that question that you have in front of you when you go to take your MOC at the end, this is so different than medical school when you walk up and you say, what's on the test? I'll tell you what's on the test. The answer will be anything but a TAF or a dolutegravir regimen, and then you'll get the answer right. And you'll see that there's only one right answer when you eliminate that. Yes, Kristen.
Just to ask the
Microphone.
question, if someone comes to you and they're suppressed.
Microphone.
I'm sorry.
Sorry, yeah.
Sorry. So if someone comes to you and they're suppressed on their regimen of TAF and dolutegravir, and then they're test positive for pregnancy, do you then switch them? And that has been what I have done, but I'm not sure if that would be the guideline.
I would lean that way till I had more data.
That's what the
and this is a little
guidelines say.
different than just kind of a lot of the wishy-washy stuff we've been dealing with before.
Just to throw it in, L-vitegravir guidelines do not recommend. That was on the list there as well.
Because of Kobe. Yeah.
Just because it's new and because of the Kobe.
So the guidelines say that if a woman is suppressed on a regimen, that you should not switch. That's
on
specifically
efavirenz regimen.
No, on any regimen. No, that's what it says. I don't know what's right, but I'm telling the guidelines say that if a woman is stably suppressed on whatever regimen, because by the time you know they're pregnant, they're almost always through the first trimester. This just came up on a woman who was on.
Yeah, everyone's agreeing.
Okay.
All right.
Sorry.
So there you go.
That's why we have panels. That's why we have panels.
Okay, we'll let the audience have last word. Here we go.
Hi, Sally Cooper. I'm from Florida. So along those lines, a lot of patients don't plan their pregnancy, and you'd leave them on the same regimen. But I've had several women that are on a stable regimen, but they want to become pregnant. Do you switch them if it's going to take them 6 months to become pregnant, or before they try to become pregnant, do you switch them to one of these acceptable regimens?
We do have incomplete information. That's why the guidelines, it's not that any of those drugs will hurt, but we just don't know. Even, Joe, the stuff that you presented with the dolutegravir pregnancy, at the end of that presentation, they said, we still have incomplete information.
Absolutely, right. No, I completely agree.
Okay, we have some questions. This has been very dynamic, very great participation here. I've got some questions. We've given 10 minutes from the time gods, and these are the conclusions that we had. There's debate about whether or not to treat elite controllers that you heard. The presence of M184V does not affect the initial regimen that much, except when abacavir at higher levels, and for rilpivirine, as we talked about. Primary and secondary MIs are distributed equally based on cohort data. Hold off using TAF or dolutegravir, and for that matter, cobicistat or alpha-tegravir. In pregnant women, if you have the choice, do not change therapy if persistent low level viremia. Those are kind of the take-home points. Got a series of questions. We'll go rapid fire. Anybody on the panel can answer. This is directed to Dr. Gulick. Can you get us tickets for Hamilton? And then, if somebody is undetectable on meds, could they be reinfected if they have sex with another person who's got some awful mutation like K65R, yada, yada?
There's been good documentation in the literature that that can happen. Superinfection can occur. It must be pretty uncommon or rare, but it happens.
Yeah. If somebody has an M184V, Joe, I asked this to you, and they're on TAF-based alvategravir, should you add darunavir just to be extra safe?
If they're already on therapy and they're supposed to, no, I wouldn't.
Yeah. Okay. Or were you going to start them? Would you double down on the 5-drug regimen?
I would do a tripsen, which would use a drug with a higher barrier to resistance than alvategravir.
Okay. Deeks, you all have thrown mega hard at people and just gotten people throwing up on you when they come to clinic.
I'm all about simplifying these days.
Simplifying. Okay, good. Could the panel comment on the risk of CNS side effects seen with integrase inhibitors? So there's drug wars out there that Company A is accusing Company B's drug of causing depression, and Company B says, no, your drug causes depression, and your drug makes people's toenails fall off and all kinds of things. So what is the truth? Anybody have data on mental health issues on strand transfer integrase inhibitors?
I think it's been reported with all three of them, and there's very little comparative data to decide among them which is the bigger offender.
There are cohort data from Europe that would suggest that maybe with dolutegravir there's slightly more CNS side effects, but it's all, it's cohort data. It's not randomized and comparative. There's in the study of dolutegravir versus bictegravir, both with TAF FTC, if you looked at the all the various adverse events, I didn't show and maybe Tripp could show it tomorrow, you didn't really see any difference between the two.
So the answer is probably not a huge difference. Here's an Alabama, Georgia, Florida extrapolation from sub-Saharan Africa. If you live in this region and you have a patient with a CD4 count less than 100, do you routinely check cryptococcal antigens in the serum? Because they do that in sub-Saharan Africa, and there's high prevalence in our neck of the woods, as they would say.
I don't routinely do it.
I don't either.
Right.
And you could argue, but I think it's a cost-effectiveness thing. And if you did find it, and let's say it was a significant titer, that's significant, right? If it's 1 to, say, 128, that's not an error. That's probably that person has crypto. Then you want to do an LP and rule out the CNS, because if they got that, you got to treat it like meningitis. You don't give fluconazole. But if it's negative in the CSF, positive in the serum, you would be okay using fluconazole in that setting, and that's exactly what they do in sub-Saharan Africa. That all said, I don't think we see, but what do you think, Jim, maybe 5 to 10 cases of cryptomeningitis a year now? It's not that common, so you base it on what you're seeing, I guess. It's common you do it, and otherwise you don't. Dr. Deeks, what is an acceptable CD4-CD8 ratio? What do you want to see?
Oh, normal range is in the 1.0 sort of above range, and that's desirable. In the cohort studies that have been done out of Europe, there appears to be a dose effect between the ratio and your excess risk of morbidity. Even after controlling for the CD4 count, you don't really see a strong signal until it goes below 0.3. Most people in the context of treatment are in between those two numbers.
All right.
But if you had an elite controller that you're on the fence and their CD4-CD8 ratio was 0.5, like that would push me towards treating that person, right?
Yeah, absolutely.
Yeah. Here's a question about a question I used to ask, and I took it out because I figured people had seen it, but I'm going to ask it as a question. So, you got somebody who's on therapy, successful suppression, and their CD4 count initially was, say, 50, and now it's hovering at about 130 to 150, but it's not going above 200, and you got them on PCP prophylaxis, and they've never had PCP before, and it's been 2 years. Do you continue the prophylaxis or can you stop it?
You can stop.
You can stop.
Good-
Okay.
Good
Well,
cohort data to show if CD4 is between 100 and 200.
Right. What if it stays less than 100? Probably not. It's the data aren't great, but that one study that is a 2011 CID article that showed that the relative risk for PJP was started to go away after a year's worth of suppression and CD4 between 100 and 200, but not less than 100. Patients who are self-injecting testosterone and others self-inject estrogen and others self-inject B12. Can cabotegravir be given in a self-injector?
I think they're exploring that. It's an IM injection. All the studies to date have given the shot in the gluteus intermedius, which I had to look up in a anatomy book to know exactly where that was. It's kind of, you got to go into the side a little bit, but right, Tony, gluteus intermedius, right? So I think they're certainly going to explore it, but I don't know that they've started looking at that yet in terms of PK.
There's a big difference, right? And we have a lot of nurse practitioners in the audience here today, and most MDs have not given an injection except maybe once in medical school, and they didn't do a very good job. You know, my sciatic nerve still hurts from my buddy doing it. So there's a skill to doing it, and there's a lot of knowledge set to get it right with, remember, the Z and all that stuff. I don't know that it's ever going to be ready for the home game. Not that one.
Don't you think, though, the desire to maintain good records about adherence would actually force this to be done in the clinic as much as possible?
Or in a clinic setting, yeah.
Right.
I mean, it could be done, by a trained, pharmacist or, the health department or, some close, but yeah, I would agree with you.
Real quickly, Steve, how often do you follow your elite controllers that are not on therapy?
Oh, I don't, every 3-4 months, I guess, for viral load check. It varies. I mean, the risk, so viremic controllers, those who have low-level viremia, they fail and progress at appreciable rate. Truly elites often stay elite indefinitely. It's rare to see them fail. So it depends on what their steady state viremia would be. I mean, that'd be one reason you'd be following them.
It's a question about drug interactions, specifically with raltegravir and statins. Are you all aware of any data, good or bad, that, I mean, theoretically it should be okay because it's only glucuronidated and there's no ritonavir. I don't know either, but I would pick up all the integrase inhibitors. The one huge niche for raltegravir is that it's the least likely to have drug-drug interactions, and that's for a lot of situations, including TB therapy and some other things. Initial regimen M184V with rilpivirine, TAF, and FTC. Would you add dolutegravir to that, or would you just go to dolutegravir, TAF, and FTC?
Yeah.
Do the latter. Okay. No need to include the rilpivirine. We've got 2 questions left in 46 seconds. Ryan White Clinic, can we trust the seronegative pregnant and PrEP? Also, we're going back to the story that we talked about for a while on the discordant couple, and the OB refuses to give them the therapy when they're pregnant. In other words, it's sort of adding an extra twist to, you got a serodiscordant couple, man, woman, guy's positive, woman's not. You think they should, woman wants to go on PrEP, and the OB says, I'm not going to do it or not going to approve it. I guess you just found another OB doc. Okay, fair enough. And then this is referencing a study in Botswana where PIs have a treatment mortality. Are you all familiar with that study? No. I didn't know that study either. But I guess the take-home point, a lot of things that are studied elsewhere, and that includes Europe as well, not just sub-Saharan Africa, it's a different population perhaps than we're treating. I will tell you the cryptomeningitis studies out of sub-Saharan Africa have a 60 to 70% mortality rate, and a lot of that's been extrapolated to the US, which really isn't a fair extrapolation because our mortality rate is less than 10%, in some places less than 5%, so it makes it difficult. All right, thank you for hanging in there with me and putting up with the nonsense, and we'll continue on with the program with something a little bit more interesting.
Nicely done.
Next, I want to say two things. First, for Joe Aaron, that by statute, people in the Ryan White program are supposed to be providing care according to the federal guidelines. So federal guidelines need to change before we change our expectations of the Ryan White program. So that is something to look forward to if you're sitting on a guidelines committee. Next, that I failed to mention that the workshops that we will be going to immediately after this presentation and then question and answer period are one floor up. So on one side of our current floor, there are stairs, and on the other, there's an elevator. So you can get up one flight either way to go to the workshop rooms. I am very pleased to introduce Professor Siegler, who is at Cornell and is a professor of geriatric medicine, is going to be talking to us about practical aspects of caring for people aging with HIV.
These are my financial relationships. What I'd like to do today is introduce you to aging, get you thinking about what you're going to do for your patients, talk a little bit about aging-related syndromes, and give you an introduction to geriatric assessment. So the first thing is that HIV care and geriatrics have a lot in common. We I think, look at our patients in very much the same way. I think you all, in many ways, are geriatricians in the raw, and what I want you to do is begin to think about how you're going to identify patients who need geriatric care and how you're going to include that care within your practices. So you may have seen any number of articles that are documenting that the population with HIV is growing older. This is one example. If you start here at the 50 and older, the proportions by 2030 are going to continue to grow. The other point is that this group here, which is the 70 and older, and this group, which is the 60 to 70, will also grow rather dramatically. So what does that mean? Well, the first is something that you've all observed, which is that older people with HIV have more comorbidities individually and have more multimorbidity, that is, combinations of comorbidities. And the consequence of that is that HIV is going to increase all the costs of care, such that in this, again, older 60 group, the cost of non-HIV care exceeds the cost of the antiretrovirals. So I think that people are well aware of the problems of comorbidities, and much of the discussion that preceded this one talks about managing antiretrovirals and comorbidities. But for caring for the older patient, we have to talk about, we start with comorbidities, and we have to talk about aging itself and geriatric syndromes. So I wanted to first cover what could be the sort of basic clinical principles of aging. And the first is assume nothing, that aging will occur at different rates in different people and different organs for different reasons. And I illustrate this on the left with three presidents who served 8-year terms. We tend to think that being president ages one prematurely, but there's really no evidence for that. And often what we see really are pictures that are taken 8 years apart. The second point I'll make is that we remain sexual beings for all of our lives, and that all of the discussion that we've had so far about PrEP is relevant to any age group. aging with HIV is going to differ from acquiring HIV later in life, and I think some of these data we're still working out. On the left are data from Giraldi looking at, in the blue, people who acquired HIV earlier in life, in the green who acquired it later in life, and those yellow who are HIV negative. The patterns of comorbidities are different, and I think we need to try to understand why. The other, and I think more important point is that, again, the chance of presenting with full-blown AIDS increases the later you're diagnosed, and I think that may very well reflect our bias as clinicians to not think of HIV as a reason one might present to the hospital. So by the time, these are CDC data that I graphed, by the time you are in the 60-plus age group, if you are newly diagnosed with HIV, the chances are very, very high that you're presenting with AIDS. The second point that I want to bring up is that environment and genes influence how we develop and how we age, and I think that this is very, very important as we try to decide how we are going to create a healthier environment for people who are aging with HIV. These are data looking at mortality before and after the fall of the Berlin Wall. And for many of the different cohorts, the difference in mortality, this is the annual probability of death, between West Germans and East Germans, all those differences pretty much go away after 10 years. So that the provision of appropriate medical care, of healthier diets, of all the things that we think are important, actually, we've demonstrated in the fall of the Berlin Wall how within 10 years the mortality gap could disappear. Third principle is that aging leads to diminished reserve, and renal function you're well aware of. In general, the GFR is going to decline with age. This isn't true, again, for everyone. On the table on the right reminds you not to be comfortable with a serum creatinine of 1, that in someone who is very old, that can reflect a significant impairment in renal function. Aging changes often cause uncommon presentations of common diseases, and the syndromes of multifactorial origin we'll talk about a little bit more later. But these are data examining presentation of people who were ultimately diagnosed with a myocardial infarction. The table on the left is looking at how many by age presented with chest pain, or for that matter, even had a cardiac diagnosis. And the older they were, the less likely they would present classically or even be diagnosed correctly. The table on the graph on the right is examining the frequency with which people who had heart attacks presented with symptoms of heart failure. And in the very old group, about 40% presented with heart failure rather than necessarily with chest pain as their way of manifesting an MI. As we see our patients growing older, the reduction in physiologic reserves impairs recovery from stress, and the term that we often use is called homeostenosis. That is, as we age, our ability to recover from a stress is less and less, to the point that we cannot recover from a stress. So that individuals who are younger can recover. Individuals who are older, who have lost the physiologic reserve, end up with significant functional impairments or even dying after a similar kind of stress. Now, I'd alluded to geriatric syndromes. We call them aging-related syndromes because many of our patients are not going to be truly geriatric. And one point I want to make is that these kinds of aging-related syndromes may have a greater impact than comorbidities on the functioning and the quality of life of the individual patient. So a geriatric syndrome is defined on the left. It's a clinical condition that doesn't fit into a discrete category and crosses a variety of boundaries. And falls, delirium, dizziness, incontinence, frailty are all examples of geriatric syndromes. Traditional syndromes, and AIDS is a classic traditional syndromes, differ then from geriatric syndromes because the classical syndromes are rare. There's a specific cause that usually isn't known, and there can be multiple manifestations. Geriatric syndromes, and you can think of dizziness or falls as an example, are common. The causes are multiple. There are cross-disciplinary manifestations, and they are frustratingly difficult to treat and prevent. So another aging-related syndrome that you've probably heard about, and I'm going to talk about a little bit more today, is frailty, and that is characterized by diminished strength, endurance, and other physiologic function. It can be measured in one of two ways. It can be measured as a phenotype, that is this person weak? Is this person slow? Is this person losing weight? Or it can be measured by what's known as an accumulation of deficits. That is, if I measure a bunch of things, does this person have a deficit in a large enough fraction of them to be considered frail? It increases the risk of dependency and death and is correlated with a variety of other factors. And we think it's treatable. So aging increases the risk of frailty. That should not be a surprise to anyone here. The point that I want to make is that frailty is not disability. Frailty is vulnerability. And the two are often confused. HIV increases the risk of frailty even after the introduction of antiretroviral therapies. These data are looking at a series of cohorts, the first before effective antiretroviral therapy and the solid line from 2000 to 2005. And what you can see is that the risk of the frailty phenotype, which is the y-axis, increases dramatically with the nadir CD4. And the odds ratio increases with each decade of age. The graph on the right shows how frailty and HIV are synergistic in terms of increasing the rate of the risk of mortality. So that the yellow curve down here are those who are both HIV positive and frail. These are negative, and this graph is HIV positive without frailty, and this is HIV negative with frailty. So that the two combined have a huge impact on mortality. Now, older people with HIV have significant impairments, and I'd like to step back from all the comorbidities because I think you're all well aware of them, but I want you to begin to think about all of the other impairments that we worry about, and this is UCSF's Silver Project. And there are several things I want to point out. The numbers on the right are general descriptions of the percentages with a variety of impairments. And you'll see 40% had fallen within the past year, a third had cognitive impairments, a third were lonely, more than a quarter were depressed, only half had normal social supports. The table on the left compares those between 50 and 59 and those who were 60 plus. And it's important to recognize that while we tend to lump them together, they really are two different groups of individuals. And these data outline some of those differences. As you might expect, those who were over 60 had a much higher likelihood of a balance problem, were less likely to be in excellent or very good health, had better medication adherence, and we're more likely to walk more slowly. So that as we begin to think about how we're going to prepare for an aging population with HIV, these data warn us that the group between 50 and 60 are going to have very different needs from the group that are over 60, or for that matter, the group that's over 70. Each is going to require a different kind of help and I think a different approach to what their needs are going to be. So this shouldn't be a tremendous surprise to you. This is sort of my way of looking at what our patients need. And again, for those of you who care for people with HIV, you understand very well all of the issues that go into caring for patients and all of the concerns patients have. What we add as geriatricians are down in the biomedical side, which include the comorbidity, aging itself, function, and frailty. So, and for that reason, I want you to think of HIV, of caring for people who are aging with HIV, as more than managing the viral load and comorbidities. It certainly starts with that, but that's an incomplete view of what geriatric care, what aging care is going to be about. So that in addition to the physiologic burden, we need to begin to prepare for the aging-related syndromes like frailty. We need to understand what the psychosocial stressors are going to be and how they differ for people who are older than 50 or older than 60, and how they differ from younger individuals. What their functional and their affective and their cognitive status is going to be and how that's going to change. Ascertaining advanced directives and determining goals of care also become a very important part of what we do. So we'll begin with the fundamentals of geriatric primary care, and again, this shouldn't seem too different from what you're used to. It's comprehensive assessment, it's creation and implementation of a plan of care, care coordination, and active engagement by the patient. This sounds, I hope, very familiar to you. So what I wanted to do was spend a little bit of time looking at some of the geriatric assessment tools. For those of you who are going to be part of the workshop, we'll go into them in more detail and get some practice. So the first is assessing function. And the table on the left describes the basic activities of daily living and the instrumental activities of daily living. And we often assume that people can do these, but it's always worth asking. To the right is the construct of health and well-being, which is somewhat different from function. This is from the SF-36, which is a research tool, but the domains are well worth looking at. In addition to physical functioning, one is interested in pain. One is interested in the patient's assessment of his or her health, how they are functioning socially, how they are functioning emotionally. These are all aspects of health and well-being, and all things that we need to ask about and touch upon, at least to some degree. We are interested in prognosis. So much of your time has been spent keeping people well and alive, and perhaps you and your patients have been working together for 25 years. As they grow older, they have to begin to think again about how much time they have left, and if they are burdened by a variety of comorbidities, what choices they want to make. The VAX calculator, which is Amy Justice's work from Yale, is highly predictive of all-cause mortality, and she has used it as another measurement of frailty. It also just gives us a sense of someone's overall mortality, or what their chances of being here in 5 years are. These are online, and you can use it either from your computer or from your phone. Frailty can be assessed in a variety of ways. The tools were originally designed for research and can be a little difficult to use in the clinical situation. These are the two frailty competitors, the frailty phenotype, Fried's frailty phenotype, which is again a description of the phenotype of frailty, of what someone looks like. To the right is Rockwood's Frailty Index, which is based on the idea that frailty can be measured by how many things are wrong with you. The Frailty Index, I think, is less intuitive. On the other hand, what it does include are a variety of things that the phenotype doesn't include, which encompasses some psychiatric and social data that is not in the original phenotype. Now, a lot of these are just too difficult to use in a standard clinical situation, and there are simpler frailty screens. This is the Frail questionnaire on the left, and the Gerontopol is on the right. I use the Gerontopol. It's a nice way for me to ask starting by asking the patient individual questions. You know, are you tired? Is your memory okay? But ultimately, it's my decision about whether that person's frail or not. If the person has at least one answer, the answer is yes to at least one question, then you as the clinician are asked, is this person frail or not? So sometimes they're worried, but they're actually doing fairly well. Sometimes they don't answer yes to a lot of the things you think they would. It gives you a chance to just look at the patient and ask some questions and ask yourself, how's this person doing? We encourage screening for cognitive impairment. The mini-cog can be used as a very, very quick check in the office. It doesn't require that you print out a piece of paper or remember anything. It's just 3 nouns and drawing a clock. The MoCA, the Montreal Cognitive Assessment, will pick up mild cognitive impairment. It is available online in a huge number of languages. You just have to sign up. So it is also available for people who are visually impaired. So that is often the test of choice for many clinical programs. And again, we'll talk a little bit more about this afternoon. Now, people aging with HIV have non-HIV dementias. This is, again, not to say that CNS inflammation or prior CNS damage has no relevance in causing cognitive impairment, but what we are trying to emphasize is that as people get older, the same reasons that they become cognitively impaired in people without HIV are going to occur with HIV. And I've had several patients who've wanted to see me because their mothers had Alzheimer's disease, and they were concerned that they might have it as well, or they wanted to understand what their risk meant. So that as with many other things, there are HIV-related contributors. But there are all the other things that all the rest of us get, and they all are combined. In this case, what we want to do is screen. And what we want to do is try to assess what the individual's cognitive status is and how that impacts their lives. Then you're concerned about how to manage their medications, what kind of community-based support services that they have, and how are they going to prepare. I have also found that one of the roles I've had is to try to encourage people to think about bones. Geriatricians are terrified about bones. That's unfortunately one of the things that we deal with fractures are one of the things we deal with fairly frequently. And so one of the roles that we've had is to try to raise awareness of bone health. There are several algorithms available to help you decide when people should be screened and when and whether medication should be started. It is, I think, often a kind of emotional decision nonetheless, and I encourage you in your clinics to develop a protocol so that everybody together is deciding exactly how the screening will be done and when people will be started on anti-resorptive medications. The FRAX is available to help screen for fracture risk. It's not the most sensitive, but it's still available to help you decide or perhaps to give you a little more of a push. The FRAX is only available online, and I want to point out a couple of things. One is that you can't calculate it or develop your own spreadsheet because you must choose your country, and then you must choose the ethnic group and the gender of the individual whose FRAX score you're calculating. So each of these has to be chosen before you enter the information. The other point is that this is secondary causes of osteoporosis, and the consensus is that if an individual has HIV, that should be marked as yes. Remember also that fractures involve more than bones. They certainly are associated and linked inextricably with fall risk. As well as strength and other forms of physical impairment and fear of falling. And all of these things must be addressed when we're trying to understand how we're going to keep our patients from falling and fracturing and changing their lives. The panel discussion that preceded me was to me awesome because I find it extraordinarily difficult to keep the medications straight or to understand how they're going to interact with the medications that I would like to prescribe. For those of you who need a little bit of help, the Liverpool app is up to date and very, very helpful in determining what the drug interaction risks would be. One point that I would emphasize is that in geriatrics we fear polypharmacy, and I will say that it's been almost impossible for me to make a significant reduction in the number of drugs that I've in patients I've consulted on. But I also want to emphasize that one of our responsibilities as geriatricians is to avoid or help you avoid therapeutic nihilism as well. If the patient needs the medicine, you shouldn't be afraid to give it to them. What we have to figure out is having which medications we can stop. How often can we look at the medication regimen that someone has been on for a long, long time and say, no, they don't need this anymore? So CGA can't be completed in an hour. This is what we do. And in addition to what I have pointed out, I do a quick depression and anxiety screen. I watch the person walk. I ask about hearing and vision. And I ask them about their goals. All too many of them tell me they have none. And it's important for me to get a sense of what they feel their future is. By even such simple questions as asking, what's important to you? What do you want to do? How might a geriatric approach help people aging with HIV? Well, again, as we've talked about, sometimes the matter is just bringing to your attention what aging-related syndromes. That this person is likely to fall, that this person is frail, this person has a lot of problems with dizziness. We will test for functional and cognitive impairment. We can help with the establishment of priorities. I think most of you have good relationships with subspecialists, and the problem is not necessarily the identification or the treatment of any one comorbidity. It's how in the world you balance all of them and how you make the decisions to treat one and perhaps withhold the medications for others. We can encourage you to think about prognostic scoring and screening. We can be yet another voice against smoking and other high-risk behaviors. It certainly doesn't, they don't stop at the age of 50. We can help you with the management of social burdens, and we can help you not just obtain the healthcare proxy or the durable power of attorney for healthcare, but actually to begin discussions about goals of care. Lastly, I want to just remind you that we really have to combine the components of care, and the geriatric part, to me, is the easiest part, because it just means I'm there in the clinic helping you. I'm just another doctor added to the mix. Where we really have to begin to be creative is how we're going to combine HIV and geriatric social services, how we're going to reimburse, how we're going to prepare for the long-term care needs of these individuals, and whether we can convince insurers to be flexible in how monies are going to be spent to help individuals lead long and healthy lives. So with that, I'll stop and we can have some questions.
So thanks very much. Any questions? I encourage people to go to the microphones if you're in the room. So one question is, should all patients with HIV who are on medication be on vitamin D to preserve bone health? And I guess a similar question that I think will come up is around when you do DEXA scans on everyone that's been on tenofovir for a decade. Like, how do you make those decisions? My feeling would be they probably should be on vitamin D, but it's I think that that's edging into areas of controversy. Certainly the geriatric literature is suggesting that vitamin D can be helpful not just for bone health, but perhaps for reducing the risk of falls. The claims about anti-cancer effects or any other effects I think have not been held up, but I don't think that there is harm in having someone on vitamin D, and I think that the attention to bone health is I'd rather overdo it, because I think we've been underdoing it for such a long period of time. In terms of when to do a DEXA, what I'm going to do is I'm going to punt to the algorithms that have been created in the literature. I've posted 2, and I think that, again, in general, it does not hurt to do one. I think what the argument is, for men at 50 and older, women who are 40 or who've hit menopause and older. The problem is not doing the first one. It's trying to figure out, okay, well, you got one that's okay now. When do you check it again, and how do you adjust the medications for that? But my experience has been that we've not been as attentive to bones as we should be. So I'm going to err on the side of urging you to do it, to do a FRAX, to get a DEXA, just to get some information, just to begin to train your minds to think about bone health. And then if we want to peel back because the information has not changed our management much, I think we'll be able to do that once we get some more information about what it would mean for a practice to have a universal set of rules. I think the other thing that, the other exciting information is will there be ways to give bisphosphonates at the time antiretrovirals are started as a way of preventing damage to bone? And I know there's an intriguing literature out there, but I'm trying to stay away from
the management of HIV disease, because you all are far better at that than I. But I would encourage you as a way to again think geriatrically, even before your patients are older. Is the literature good enough for you to begin to think about giving a bisphosphonate upon initiation of ARVs?
Great, thanks. I would say that the question about patients that are on efavirenz, TDF, and 3TC, we were discussing those patients earlier and just really don't want to change off a regimen they feel comfortable on. I'll often do a DEXA scan and show that they have osteopenia, and that'll get someone who is just really attached to a regimen that saved their life, like I can understand the emotional attachment to it, to rethink it a little bit. So I tend to use DEXAs anyway, but that's a very good point at which to use DEXA in my practice. So we've got several questions here, so maybe quick answers. So why is a mental status exam not recommended for cognitive impairment?
It's a bit of a political question at this point. First of all, I think that the MOCA has better data at this time. The mini mental status exam is now copyrighted, and you are supposed to be paying a little over $1 each time you use it. The company that, and academics is not as freewheeling as we would like it to be. The company that manages the copyright has been a bit difficult, and as a matter of fact, if I remember the literature correctly, and had actually halted the development of another mental status exam called the Sweet 16 because it was felt to be too close to the mini mental status exam. So my main concern is that there's a business involved with MMSE now that may make it difficult for you to comply with the regulations that they've established. And I think the MOCA is better. There have been some articles published, and I think I have one reference up on the slide that talks about the politics behind the MMSE in far more detail. So I encourage you, if you are deciding between the two, to pull the literature to understand the barriers to using the MMSE.
Okay, another question. It seems like there are greater effects of cognitive decline in geriatric patients living with HIV who are age-matched to HIV-negative patients, but their MRIs don't show traditional plaques associated with Alzheimer's. Is that something that we know about? And two, is that because of that low-level replication in the CNS reservoir that somehow HIV in the brain is impacting development of Alzheimer's?
There are about 5 points to the question. Let me see if I can get. MRIs show a variety of things, but they will not depict the pathology. So it's difficult to know exactly what's going on at the pathologic level unless you're part of a study. What I will say is that things that often what we call Alzheimer's disease is really a combination of vascular as well as degenerative disease. So if you want to compound that by talking about active viral replication plus inflammation plus all the other multiple reasons why people without HIV get demented, they're going to work synergistically. I'm not I'm not a neurologist, so all I can do is say that they're even in those without HIV, why one gets demented is far more complicated than 50% Alzheimer's and 25% vascular. There are a number of factors: head trauma, alcohol use, vascular disease, as well as the family histories that lead to the development of a dementia, what we're saying is that HIV replication chronic inflammation are just going to add to what is already a very complex mix in those without HIV.
You addressed the issue of sexuality at an older age. I think there's some individuals that are fortunate enough to keep their sexual activity alive. I don't think that's the majority in my experience. And we continue to do annual testing for RPR, chlamydia, et cetera, GC. My experience is that this is not a cost effective. I don't know, these people kind of look at me funny when I say, yeah, you need to pee again, and say I haven't had sex in 15 years. So, I mean, how reliable is asking them, are you sexually active? And if they're not doing these tests, because we have applied the risks from a younger population to an older population, and the outcomes are clearly different, and I wonder if you could address that.
I mean, I think that as many of the questions that have come up earlier today, what you do often depends on how much you believe your patient. And so, whether you choose to screen annually for STDs depends a lot on whether you feel your patient has been telling the truth. And I certainly applaud not doing inappropriate testing in someone where it makes no sense and where, as a matter of fact, it's telling the patient you don't believe what they're saying. What I was focused on more, at least in that, I'll say 2 points. One is I'll also say that the absence of sexual activity does not, and you know this, does not mean the absence of sexual interest, and so we cannot assume that the failure to be sexually active for 10 years would not mean that, given the opportunity, someone would not have another relationship or another interaction. So it's what your relationship is with your patient and whether you feel that they're being honest with you, and then saying, okay, we'll not do this, but let me know if the opportunity arises and I need to test you again. The other point that I was trying to make is that we, in the general medical clinics, there is an assumption that older people are not sexually active, and that's a dangerous assumption to make, and so. We encourage our house staff and we encourage others to ask the question and to take a sexual history irrespective of age. And that's really the point that I was trying to make. The other point is that often, especially for women, there's a sense that there's no need to use protection anymore because in the case of women, they're not going to get pregnant anymore. So there's the condoms are not necessary. That there isn't often an abandonment or an assumption that all of the warnings and all of the directives that are geared toward younger people don't apply to them. So that I think if you start out with the assumption that I don't know what this person's sexual behavior is and I must ask because I'm not going to assume that age is precluding sexual activity, then you have asked and you have information and you can act upon the information.
Okay, we have two. We have one question in the audience, a quick question, quick answer, and then I have one written here that I want to get to as well.
Okay, just a comment. Thank you for your presentation. I mean, just one marker for my clinic is, my older patients asking for, Viagra and Levitra, et cetera. I mean, that's pretty much a marker for, continued testing and the conversation around STD. The question for you is in your patients. I mean, I guess I have a question about how much, do you have a limit to the amount of erectile dysfunction medicines you're going to prescribe your patients? I mean, I have someone come every visit. They want them. And do you have any, I mean, I don't know if you mentioned it, any issues that you may have in this population using those medications? And just one thing about his comment about testing patients who are older, I think for us in Ryan White providers, the standard doesn't matter by age. And we have to do STD screening every 6 months, even if they're not active. And they asked me, why are you testing me for syphilis? I said, well, because an auditor's going to come here and check the box. So, I think many of us might probably understand what I'm talking about. So,
no, it's a very important point. You have to do what you need to do to maintain your funding, and this is an opportunity to go back and see if some of the standards can be adapted so that they make more sense to you. I'm also going to say that most of my practice is general geriatrics, so the question of too much ED medication, I will say, has not come up, in at least with the patients I have. I certainly do prescribe it, but I'm going to defer in terms of how much is too much, because I have no experience in that.
Okay, and so the next question, last question we'll be going to the workshops is, so a geriatric patient with chronic pain trying to avoid chronic opiate use, maybe in terms of falls and all the reasons we're not trying to use less opiates, non-steroidals, many people can't tolerate those, Tylenol, at times with hepatitis or other reasons they can't use a lot of Tylenol. What do you do for managing chronic pain?
How much time do you have?
Well, just I think a general approach.
Yeah, no, I mean,
is there particular
again,
medications you go to, and is there a general approach around physical therapy or other approaches?
I believe you're going to get a workshop in that Wednesday. So by a physical therapist. So we're going to start with. It must be multimodal, and obviously physical therapy, strengthening are key parts. The question of medication, I think, goes to the more complex question of determining what the source of the pain is. Is it neuropathic pain? Is it arthritic pain? Is it does the person have spinal stenosis? The choice of medications is dependent so much on what the etiology of the pain is that you can't have a one-size-fits-all. Opioids are something we try to avoid, but we are looking, I think, more and more at medications for neuropathic pain like gabapentin and so on to see if they can be opioid sparing. But I think that the first step is, rather than just choosing the medication, is determining the etiology of the pain, and then you can begin to do drug trials. I will often work as well with our pain experts, so that if we can find an injection or another intervention that can help ameliorate the pain, and we don't have to look just at medications. We can look at spinal stimulators and other things that I have found to be remarkably effective in some of my patients. So I think what I'll say is the first step is trying to step back for a second and try to determine all of the components of the pain. Recognize that physical therapy, cognitive behavioral therapy, other kinds of non-pharmacologic treatments are going to be very helpful. Treating the specifics of the pain will be very helpful, and working with your pain experts to determine if there are invasive or in other interventions that can offer more specific relief and spare the medications.
Okay, great. Thanks very much. We are on to the workshops now. So everyone, it's one flight up. Thanks very much. Thank you. Thank you.